find it helpful to kind of know how we get here and why we do what we do to really understand the risks associated with it. And then hopefully I can tie in some practical considerations, particularly for the internists and our co-management colleagues. So we'll start with the history of aortic repair very briefly. I always just think it's really interesting. Aortic aneurysms, or I just actually just arterial aneurysms, have been described from pretty early on by the Egyptians, and they used to call them tumors of the arteries. And treatments have really ranged from ligation and aneurysmorphy, so kind of just trimming things, packing things. And as you can imagine, suddenly blocking blood flow to any major organ is never a good idea. And so in 1939, Page tried a technique of wrapping an aneurysm with cellophane. So really going from the outside, as you know, EVARs are from the inside. And so he first did this for actually kidneys and to induce hypertension, and he would wrap around the cellophane and hope that it induces some sort of fibrosis and limit expansion. And interestingly, probably the most famous AAA patient is this guy, Albert Einstein. So he had a AAA, and in 48, he actually had one of those now defunct treatment options, which was that cellophane wrapping. And that was done by Dr. Nissen. So if you know, like Nissen fundoplication, that's the same Nissen. And supposedly he claims that that prolonged his life for several years, free from rupture, until unfortunately he did succumb to it in 1955. So he did end up dying of complications from his rupture. But since then, we've made some progress, and I guess that kept him alive for just a few more nuggets of knowledge there. So in 1990, we had someone named Perotti. He implanted the first transfemoral intraluminal graft, so our first EVAR, and he basically used whatever available balloon expandable stent with standard polyester graft and just kind of put that under fluoroscopy. Eventually, the devices improved, and the first FDA approved device was in 1999. And as you know, technology didn't stop there. So now we're having increasingly more complex repairs done. So, as in most things in technology, that led to a shift from open to endovascular repair. And you can see there kind of what we used to do, and we still do, but it definitely is a different patient population now. And so within the first decade, you can see there's a pretty dramatic increase from 5% to 74% of the AAA repairs being EVAR, and the in-hospital mortality actually went down by 50% for both ruptures and unruptured aneurysms, as well as there being an associated shorter length of stay. You can imagine it's significantly less morbid, so the recovery is actually much better. And so multiple studies since then have shown the feasibility and overall lower perioperative morbidity and mortality with EVAR. But what about long term? So Dr. Schermerhorn looked at this in the Medicare population. He found that the overall perioperative mortality was really low at 1.6% for EVAR compared to about over 5% for open. And the advantage was sustained through the first 3 years. There may have been some loss of that advantage at around the 8-year mark. But of course, this is from our initial studies based on older versions of our endografts there. And then we had some other studies to kind of reinforce this data. The UK randomized control trial showed some lower mortality at the 0 to 6 month mark. And then beyond 8 years, again, there was a significant higher mortality after EVAR. And so that really goes to show maybe the initial durability concerns for endovascular repair. And so with the improvement in our technology, all of our guidelines continue to change. And as you can imagine, as more data comes out, the guidelines evolve. So the last ones are promoting EVAR now and open surgical repairs, mostly reserved for young, otherwise healthy patients who maybe don't have an endovascular option or can handle the morbidity and mortality associated with an open repair. So what does that mean? As in the case for everything, patient selection is key. And for EVARs, not everybody is an anatomically suitable candidate. So the first generation of EVAR devices that obtained FDA market approval. They kind of look like a pair of pants. You can see here different iterations of that, different styles of pants. And what that means, though, is that these devices are really depending on healthy aorta, healthy blood vessels to hang on to. So this proximal area here, that's referred to as the neck. That's where we need the seal for all of these main body portions of the EVAR devices to seal into. Same thing distally. We need this apposition here into some healthy iliac vessel in order for these seals to be achieved and the EVAR to work and have some durability. And so generally speaking, our typical anatomic requirements are obviously out of the scope of this talk, but they're, depending on the device, different anatomic measurements that are required for them to, at least on label, on IFU per FDA, for them to be EVAR candidates. Unfortunately, though, despite the advances, multiple studies have shown that these anatomic requirements are actually often not met. So, for example, 40% of patients in this particular one had a mean neck length, so that proximal healthy aorta was less than 15, which was the minimum. And so there are quite a few patients that are not able to get a straightforward EVAR. And just because you can put a device in doesn't mean you should. So the really large devices, the really large necks, they may last for, I don't know, maybe a year or two, but really what that might mean is that it's unhealthy, but it just hasn't quite degenerated yet. And so we'll see leaks develop in the future. And so then what do we do about that subset of patients who can't get a straightforward EVAR? Well, now we have complex EVARs. And so it makes AAA complex or complex EVARs more complicated, is that the top and the bottom extent, as you can tell, spans across that visceral segment. So where the mesenteric and renal arteries are. So you can't simply put a stent across it and cover all of those, obviously. And so these complex endovascular repairs then require us to incorporate branches, individual stents to each one of those vessels to preserve perfusion in a kind of anatomic way. And so a FEVAR, I'm sure you've read all of our notes. There's FEVAR, EVAR, BVAR, TVAR, FB EVAR. I mean, there's so many. So a FEVAR is the fenestrated EVAR, and that just means that there are fenestrations, so fens, openings, through which we will put a stent across and bridge into, let's say, this left renal artery, right renal artery, and the SMA here. And so there's all kinds of configurations you can do. Same thing, a BVAR then will be a branched EVAR. And instead of holes, there's a branch attachment, whether it's on the outside, on the inside, facing downward, facing upward, in order to accommodate the patient's specific anatomy. And then, of course, you can put them together and you can get a fenestrated branched EVAR, so an FB EVAR, which is just a combination. Some may be fen, some may be branch, and that's all beyond your scope. But all of those things, just take away is it's a complex endovascular aortic repair. And so you can imagine, as patient anatomy is pretty different for everybody. It's very unique. And so some people have duplicate renal arteries, some have calcifications, et cetera. And so how do you accommodate that? You can't just simply throw in any off-the-shelf device that's already kind of laying around. And so physician modified endografts, you'll see in our notes, PMEGs, are a specific type of FEVAR, BVAR, FB EVAR that is actually just made by us on the back table. And so what we really do, and we have an FDA approved IDE protocol for this, is that we take the graft and we burn holes in based on a custom design that we've made. And we build the graft on the back table while the patient's getting intubated, they're getting their lines in, they're getting prepped in. So while the patient's getting ready, we're building their graft. And so, for example, a typical case will be this thoraco. You can see it's shaggy. That's actually a technical term we use where there's mural thrombus everywhere. You can see here, it's a shaggy aorta. It meets size criteria. It extends all the way through an extent to, so very extensive thoracoabdominal aortic aneurysm. And so we'll create a design based on that patient's specific anatomy. And then based on those measurements, build out the graft to accommodate all their renal visceral arteries. Sometimes we even put it to their lumbar arteries or the intercostal arteries to preserve blood flow to their spinal cord as well. So it can get pretty complicated. And this is kind of what it looks like. We're in the back table here, burning holes, making branches, deploying stents, and then we sew them all. We tie it all back and then we put it as if it had never come out in the first place so that we can put it into the body through a sheath. And that's an inner branch. And so for that particular patient, for example, you can see the stents are in there, and over time, I think this one was out through 5 years, you can see remodeling, which means that the aneurysm is kind of conforming to the contour of the stent grafts now. It's getting smaller, you're getting that sac regression, and that's the goal, is you want sac regression. And so this can be pretty versatile. As you know, it's custom modified. So we can make this however we need to in order to accommodate the patient's anatomy. There has since, within the last year, now come a off-the-shelf device, meaning this comes pre-manufactured It's called a TAMBI device. So a TAMBI is a version of a BVAR that just comes already made with the branches. The problem is as you can imagine, there's only one or two sizes, and so it's not a one size fits all. It can't fit everybody, but at least it captures a good portion of patients. Anyone who can't get that now goes back to getting some sort of PMEG or other fenestrated device. And so, what are the potential complications? How do we manage these patients? What are we looking for? As you can imagine, increased complexity means increased risks. And so, really, the skill set becomes critical. You got to be able to bill yourself out. And actually, patient selection as well as post operative management is crucial. So, having a certain level of suspicion for a complication before it really manifests is really, really important. And I think that's where you guys do tend to play a big role in helping us identify some of those complications. So one of the major criticisms of endovascular repairs, particularly for these complex repairs, are the need for frequent reintervention throughout the patient's lifetime. And so that's something we do counsel the patient on. They have to be willing to come in, get surveilled, continue to get CT scans because things like this, endo leaks can occur. And so sometimes you'll see on radiology reads, they'll call endo leaks almost anything an endo leak, but not anything is an endo leak. It's actually very structured. There are different types of endo leaks. And so I won't belabor the point, but basically you can imagine if there is a stent apposition to the aortic wall or to the vessel here, or in between any one of these kind of joint areas, you can get a leak and that could be pretty robust. And then you get an inlet without an outlet, et cetera, et cetera. And so those can lead to rupture pretty quickly. So certain types of leaks we will tend to treat more aggressively. We will also change our blood pressure parameters accordingly, et cetera, because essentially, especially if it's a big leak, it's an untreated aneurysm and we treat it as such at that point. So then we might, even though the patient was treated, if we find that there's a big leak, we may change the blood pressure parameters back to something stricter as if they did not have a repair. Slower leaks like a type 2, which is basically a retrograde. So you have all these branches that come out of the native aneurysm sac here, and it's retrograde filling via collaterals. Those tend to go away on their own, and or even if they are filling, they tend to be very, very slow. So we'll be less aggressive with those. We won't change parameters and protocols based on those. And then one of the most dreaded complications is SCI. So the more extensive the aortic repair and the more coverage you have, so the higher it is, the more TVAR plus VVAR plus BVAR plus IVE. I didn't talk about that, but if the iliacs are involved, if your subclavian's involved, your vert's involved, that all increases your spinal cord risk. But of course, that's not a fair assessment because not everyone has the same extent. So the higher the extent is, the higher the risk of spinal cord ischemia. They only quote a little under 5%. When I talk to patients, I'll quote them anywhere up to 10% even, depending on what I expect to cover and how much revascularization I'm able to provide them for their spinal cord. Because of that, sometimes patients get pre-admitted for lumbar drains. Sometimes we'll put them in preemptively. Sometimes they'll stay in the ICU longer. Sometimes we'll want blood pressure parameters to change. And so all of those things are things we're looking at. And so what we've done since then is developed a code SCI here at Keck. This is relatively new. I don't know if you guys have been involved with it yet, but it's very similar to a code stroke, and it gets called the same way. Once the code SCI is called, the neurology neurosurgery team and our team all respond. And it should be noted that SCI is most common immediately post-operatively, but it can happen during their entire hospitalization and can even happen in a delayed fashion. We've had a couple people come back about a month or two out with SCI symptoms. The good news is that typically spinal cord ischemia related to endovascular repair tends to be temporary. Majority of these patients recover function. And so I'll quote them, even if it can be 5 to 10%, that there are certain adjunctive procedures we can do to mitigate that. And a lot of times it's temporary with appropriate protocols post-operatively. But this is where busting out that full neurologic exam has been really important. We've had to kind of re-engage our trainees and the nurses and teach them how to do a full neuro exam, not simply, oh, can you wiggle your toes, but really testing their active and passive movement, their sensory deficits, et cetera. We also do pay attention. So if we hear from PTOT that a patient is feeling weak, they can't seem to walk, and it's not just from general deconditioning, but particularly they feel like their legs are weak, that's something we have to pay attention to, maybe correlate with their blood pressure. These are all little things that we monitor post-operatively. A lot of time you guys won't see them unless you're in the ICU for the initial treatment. But you may notice that when they get to the floor, our hemoglobin goals are maybe higher, that our oxygen sat goals are maybe higher, or we may ask for permissive hypertension, allowing the blood pressure to run up higher and asking to maybe pull off some of the blood pressure medications. For those patients. We've had a couple patients who have, for example, had a UTI that turned into sepsis. They had an episode of hypotension and subsequently had spinal cord ischemia. So we tend to be really aggressive with managing infections, making sure that even if it's maybe borderline, maybe if technically we're not supposed to be treating them, we really have that high level of suspicion that that doesn't progress into anything more, not just for infecting the stent graft, but also for the SCI risk. Same thing with GI bleeds. We had another patient who had pretty robust GI bleed, which led to hypotension. And again, they had temporary spinal cord ischemia until we were able to mitigate those pressures. So there are quite a few things that maybe you don't think are associated, but could be. And so sometimes we'll even bring patients back from outside hospital, even if their main complaint doesn't have anything to do with their aorta, because we don't think, we're afraid that the outside facility maybe won't be able to have that level of suspicion for these things and or put in a lumbar drain or do anything should they occur. Think one more thing. Oh, I put antiplatelet here. So I know every attending, at least in vascular, is a little bit different for me. I tend to be really slow with resuming antiplatelet agents. And that's because if the patient needs a lumbar drain, a lot of times the neurosurgery colleagues won't put one in if they've recently had an antiplatelet because of the bleeding complications that we've had, and we've actually reported on that as well. Exceptions to that will be obviously coronary stents or carotid stents, especially if they're relatively fresh. Then we'll talk to neurosurgery about that. And then on the other side, sometimes I will insist on it if, let's say, my renal artery stent is relatively small and I'm really worried about stenosis or complication related to occlusion of that stent. Then in that case, I might say, okay, I want an antiplatelet agent earlier on. In fact, I may even want DAPT. And so that's going to be something that we tend to pay attention to as well. And so there's this whole protocol that we've developed. It's kind of evolved a little bit. Some of these things, for example, the hemoglobin goal, we're not really strict on, but the idea is just to keep the hemoglobin up and not let it drift too far. So, we talked about FEVAR, BVAR, FBEVAR. There's obviously TVAR, so thoracic endovascular aortic repair. And so compared to everything I just described, it probably seems pretty straightforward. It seems like just singular tubes within thoracic aorta. But what makes this even more complex is you have all these intercostal arteries that you're still covering. So your SCI risk is still there, albeit maybe not as much as if you also had to go down into the abdomen. But now you have these other great vessels that you have to deal with. And as you can imagine, complications related to any one of those can be devastating. So strokes would be the biggest one. Also anatomically, there tends to be that shagginess I talked about. There really is a shaggy spore that we actually reference. And then the tortuosity can be very difficult to manage as well. So just as an example, here's one you can see it's a very angulated aorta, our wires going up into a pre-existing stent. The device is being positioned. You can see this is a different projection. So on obliquity on that other one, you can see it's splayed out. Here you're looking front view and you can't really tell that tortuosity as much. We see the celiac here. We want to make sure to stay above that. That's pre-deployment. And once we deploy, you can see that it's extending into this graft. And we balloon it to make sure it has good apposition to the aorta while preserving all of these visceral branches down here. And so you can imagine all the intercostal arteries to the spinal cord are all covered now here. The same concepts that have to do with FBEVAR in the belly and the kind of thoracoabdominal section you think about here too. So you can put fenestrations, branches, all of those things to preserve flow into your innominate carotid arteries. The subclavian's a little more forgiving, but also the subclavian artery. And the biggest thing here is mostly stroke, less so the SCI risk. And so here is an example of a patient, they had a dissection. It goes into the innominate there, the subclavian all the way down. You can see they had a prior open repair and you can see it's all kind of degenerated here. The dissection flap is right there. Huge communication and fenestration, same thing here. You can see that view. And so this patient got a custom modified FBVAR similar to what we would do in the thoraco, but this time for the arch. Again, custom measured and built. In case it's interesting, I always find it interesting to see how things are done. This is our initial angiogram. The stent is being deployed and unsheathed. after we've already made it and now it's in the body being unsheathed so that it can open up. You can see it's opening here. Yep, flowering open. This circle here marks that fenestration that was created for that innominate. And then it's going back further to finish opening it up there. This was the initial construct that was there, the open repair, and then a huge pseudoaneurysm that blew out, plus this fenestration. And this completion, you can see none of that is filling, and you have preservation of all the branches that go up to the head. Just some, in case you're interested, the stents being deployed. So, and then we bridge all of them. And so on our completion, there's this pretty nice technical result. All of these stents into the great vessels, as well as our arch, you have no filling around in that aneurysm sac that was previously there and or that dissection. And so that's the goal. And that's kind of the new frontier that we're working on. In addition to that, we've actually been working on endobentals. And so as we get more into this, I won't belabor the point, but as you can imagine, risks associated with like TAVRs plus endovascular repair, plus the arch repair, the stroke risks, the valvular risks, all of those then get combined. And those are going to be things that we need to monitor. This is still very novel, and we're kind of experimenting. We've only had a couple of patients. It's extremely technically difficult, but that might be something that you see coming up in the horizon. So for example, this is one custom-made Bental, endo Bental is what we're calling it, where you basically attach a valve to a custom-made arch graft. Kind of just, in order to kind of design these, we basically take samples home and kind of figure out how to do them. And so what are some practical considerations? I think this is probably the most pertinent for this audience here. And that's a few things. So one, access and blood pressure. So we often go through the left arm, the left thigh brachial, kind of right under the armpit, and then groins. So a lot of times we'll have you guys take blood pressure. We'll ask the nurse to take blood pressure from the right upper extremity, also because for example, dissections, or if there's any pathology in the thorax, the left subclavian often gets covered and or is affected. So the right is usually the more accurate blood pressure. We'll ask for bilateral and use the higher number, which is more often the right. And so our goals, as I kind of alluded to earlier, will really depend on what stage that patient is, what their pathology is. So for example, a dissection, we tend to want less than 120 systolic, less than heart rate, less than 80, and then we'll liberalize to SBP less than 140. After they get treated, we tend to drive it up, so then MAP greater than 80, and then we'll liberalize down to normotensive once they prove that they don't have SCI. And so the goals for blood pressure will change, and that's why it's constantly a moving target. Sometimes we'll do a repair, expect it to be MAP greater than 80, then we'll get a scan and realize there's a leak. So then we drive the pressure back down. And so it's a little bit of a moving target. That's where we appreciate you guys working with us on that regimen post-operatively so that we can kind of continue to be very flexible with the patient. You may have noticed sometimes we'll say no ACE inhibitors, no ARBs after a FEVAR. And it's voodoo, I'm going to be honest. And that's because these stents, particularly the renal arteries, are the most commonly occluded or stenotic stents. And our renal artery duplex is good, but not quite the best measure of that. And so if there develops some sort of renal artery stenosis, we don't want the patient to be on an ACE inhibitor ARB, just like if you had a renal artery stenosis patient in a native renal artery. And so we're kind of treating it like that. If all things were the same, we prefer not to have an ACE inhibitor or an ARB until we've kind of made sure that we've verified on repeat imaging that that is indeed not the case, that they don't have renal artery stenosis. Some of the other things that we kind of think about are the potential for new dissections and whether that's antegrade or retrograde. So the stents themselves have a certain amount of radial force. And so we drive up the blood pressure in order to preserve or maintain our MAP so that we can minimize the risk of SCI. But that can also then create a increased pressure on this very fragile aorta, and you can actually get a new tear on top of the existing tear. You can also get propagation of the tear forward or backwards. And so if a patient has a new chest pain after, especially after a TVAR, we wonder if there is a new dissection. So sometimes we'll get a new scan. So it's not always coronary, it's not always cardiac. Sometimes it's a new dissection that occurs, or a dissection in a patient who had an aneurysm. If a patient's not tolerating PO, has a new GI bleed, we have to think about mesenteric ischemia. Are any of the mesenteric artery stents occluded and or stenotic? Same thing with renal failure. If there's any new renal failure and or they're not recovering, the urine output drops off, then we worry about the renal stents being occluded. If on exam, the patient's still complaining of pain, they still have a pulsatile mass, obviously, it seems like we did not get the seal, and so that might prompt further imaging. And then the neurovascular exam, we talked about infections, GI bleed, hypotension, and then the antiplatelet regimen as well. I kind of just threw in some of the guidelines that we have for preoperative management and risk stratification. I pulled these from a talk I gave to our trainees from our SVS guidelines. It's a little bit outdated. It's from 2018, and obviously the evidence is really variable in terms of strength. But this is sort of what they suggest for vascular surgeons. So from a cardiac standpoint, EVAR is considered an intermediate high risk procedure still, albeit here at this institution, we seem to treat it as though it's an extremely low risk procedure. And so when we're doing a cardiac workup, these are the main questions that we ask. You know, is there active cardiac condition? If yes, then two, does the patient have a good functional capacity? And I think a lot of this is similar to what you guys already do. And then how do you assess the functional capacity is by METs. If the functional capacity is low, then that should prompt further cardiac testing. In terms of other, let's see here, other preoperative workup. So I'm just going to go down quickly what they say. So EKG, yes, within 30 days of repair. Echo, yes, only if they have worsening dyspnea or known history of CHF with worsening dyspnea or dyspnea of unknown origin. As you know, we do not necessarily follow that. We get an echo on almost anybody preoperatively. And that's because a lot of times actually our anesthesiologists find it really useful intraoperatively so that they know how to manage the patient and their fluid balance. And then maybe we can get, let's say, a cardiac anesthesiologist if we really needed to for a patient who has a history of heart failure, depending on the complexity of the repair that we're going for. It also then tells me the general anesthesia risk for a patient, and maybe if I should not do general anesthesia, should I do instead MAC? Should I do moderate with local? Because you can actually do a lot of this with moderate with local. Ruptures, we do not intubate, right? We intubate only if they're stable and we need to, but most of the time actually at this point, even for fenestrated repairs for ruptures, those patients can be awake the entire time. And so for those patients that are particularly high risk, that echo at least is just a good piece of information. Obviously not evidence-based per se, but something that we've been able to use. A cath, no, unless obviously that if the patient has any one of these things, I think that's pretty self-explanatory. So ACS, unstable angina, left main incorporated, et cetera, et cetera. In particular for us, the problem with getting a cath is that a lot of times if they get treated, they will need DAPT. If they get DAPT and they are on that and they can't stop it, not only is it about perioperative morbidity and mortality, but also the DAPT itself. Can they get a lumbar drain? Can we operate while they're on DAPT? And so a lot of times we are okay operating on DAPT, but they can't get a lumbar drain or any other adjunct procedures, and that becomes a limiting factor. So if we anticipate the patient will need it, that we might say just don't look, right? Even if the patient, if they need the aneurysm repair and they're symptomatic, we're basically weighing the risk of rupture against the risk of a cardiac event happening. And that becomes a multidisciplinary discussion. And so we may say, normally, yes, the cath is indicated, but maybe we don't do it, or vice versa. No surgery 14 days post angioplasty, since the risk is highest in the first 4 to 6 weeks. No surgery 30 days post BMS, post ES. So I think all of these things, really a lot of times the emphasis is on operating through the DAPT. And again, we don't tend to worry too much about operating through DAPT. It really is the perioperative morbidity, mortality, and then any other adjunct procedures that we may not be able to provide the patient should they need it. And then, yeah, consider EVAR under local. So we will, I will do endovascular repairs, even fenestrated ones under local. It's not ideal. We like to hold respirations to minimize respiratory artifact during the surgery, things like that. So it's not ideal, but in a pinch and for ruptures, we do them. This, I think you probably already know, but no longer are we asking for beta blockers, prior alpha-2 agonists, all these things. It's really don't initiate new medications if they weren't already on them. And it really should be an individualized approach. Okay to continue aspirin. A lot of times we'll continue most anticoagulation, antiplatelet agents, and then hold warfarin 5 days pre-op, heparin bridge as needed, and then holding DOACs for 2 days pre-op. From a pulmonary standpoint, EVAR is better tolerated than an open repair. That seems pretty self-explanatory. Respiratory failure is actually one of the main complications of open aneurysm repair. Severe COPD also, as you can imagine, increases in-house mortality quite a bit, regardless of what repair we do. And so if anyone's on baseline HOMO2 or has significant COPD history, again, they may be someone who I counsel, hey, you have a high risk of respiratory failure and or being vent dependent, you may need a trach, et cetera, et cetera. And that becomes something that I need the patient to consider if they're okay with. Um, Sometimes we'll consult pulmonary, and a lot of this is a CYA type of thing too, as well. And so for liability reasons, we will do a lot of cardiac consults, pulm consults, even though we know the answer, and or even if it may not change our management, because we do need it documented that we were able to have that multidisciplinary discussion. And then, of course, smoking cessation is always the goal. From a renal standpoint, moderate renal disease is associated with higher mortality and cardiovascular events, particularly for open repairs, open surgery aneurysm repairs. But severe, it's poor outcomes for both endovascular and for open. There is a little bit of a caveat is obviously endovascular repair, especially depending on how complicated it is. Moderate renal dysfunction can be a little bit of a pseudo contraindication just because of the amount of contrast we may need to be able to use. And so that's something that we'll have to counsel patients on as well. And so some of the strategies that are recommended in the guidelines for these patients in particular are to maintain euvolemia using either sodium bicarb or normal saline. They give a pretty specific regimen here of what you can use or what's been proposed at certain centers of excellence. So normal saline for 6 to 12 hours pre-op and post-op, sodium bicarb, things like that. We did have a protocol for FEVARs where we used to pre-admit patients. We used to pre-hydrate them. A lot of times, I'll be honest, it has to do with the logistics of getting the patient in. So we need the patient to be admitted either for a lumbar drain and or to be ready for their procedure the next day, and or to be able to get a scan beforehand so that they can get new measurements made, et cetera, et cetera. I think you probably noticed we don't do that quite as frequently anymore. We've been able to kind of mitigate some of these risks after the fact with new protocols. So not so much doing that, but these are some of the things that the guidelines recommend. Holding ACE inhibitors the morning of surgery. In general, as you know, like we mentioned, we don't really keep ACE inhibitors on while they're inpatient anyways. Hold nephrotoxic, 48-hour surgery, 48 hours before contrast. Obviously reducing contrast. So we actually have quite a bit of new software in our operating rooms that allow us to use fusion overlay and graphics and things like that. So we don't have to use contrast to identify our vessels every single time. And so that's actually reduced our amount of contrast that we use. So we use actually less than even a CT scan uses for these complex repairs often because we have that technology to be able to reduce the contrast load. Oral mucomist they recommend for at-risk patients. That's the same thing where we kind of do it as part of our protocol. It's a pretty low risk item. And so some people will get them. Generally speaking, we've kind of stopped doing that for our patients because we've gotten pretty good at minimizing the contrast load during these surgeries. And then there are all kinds of things that were proposed, mannitol, dopamine, et cetera, which they're not really necessary. We don't have enough data to drive any of those recommendations. The metformin, I think you guys already know. Platelets, we will only transfuse if they're less than 30 postoperatively, 130 postoperatively with an increased bleeding risk, or if they're less than 150, we may monitor. For these endovascular patients, though, a lot of times there's a consumptive process where they'll get thrombocytopenic anyways. And so a lot of times we just monitor. Obviously, these patients get numerous exposures to heparin. So if they meet the hit criteria, et cetera, we may go down that path where we're evaluating for a hit. But otherwise, a lot of times we're pretty liberal with allowing thrombocytopenia, kind of something we just watch and monitor unless they have some sort of complication for it. And then PRBC, so blood transfusions, we only transfuse with less than 7, unless they're, let's say, a high-risk cardiac patient and or not lumbar drain, SCI risk patient, then we may start to push it just a little bit higher. Again, it's kind of mixed evidence on that. Some cases go all the way up to 10. I don't think we're quite as aggressive because I think it's out of our institution that we said that higher transfusions or more transfusions don't necessarily improve outcomes, but we still try to keep them above 7. For general screening, this is kind of coming out of the inpatient setting. So general screening for AAA is something that our guidelines recommend. And so if you guys ever in your clinic are thinking about it, who should you screen? Why should you screen? There's been a few papers to demonstrate the benefit of screening, although this has also been a little bit of a moving target. And so what their recommendations are is that there's a one-time US screening for men and women 65 to 75 years old if they've had a history of smoking. One-time screening if they're over 75 and otherwise good health, again with a history of smoking, or if they have a first-degree relative who's had a AAA. If their initial screening demonstrates an aneurysm of about 2.5 to 3 centimeters, they recommend rescreening after 10 years. The likelihood of a rupture based on that size is extremely low. And so a lot of times the patient will actually probably forget that they have a AAA until it gets big enough and they get referred back. So post-operatively for surveillance, actually, no, this is for pre-op. If the size is 3 to 3.9, you surveil every 3 years. If it's 4 to 4.9 every year and 5 to 5.4 every 6 months. As you get to about 5.5 centimeters, that's the recommendation for AAA repair, 5 centimeters in women. A lot of that is based on just diameters and data that we initially had from really old landmark papers, but we're finding that that's changing quite a bit and that diameters may not be the only indication for rupture. But until we can really better articulate what exactly are the risk factors for rupture in a meaningful way, these are our current indications for repair in asymptomatic patients. So once they get to 5.5, until then, screening at these intervals. And you're always welcome to refer to vascular early and we can carry that on so at least they can be established with someone and we can kind of emphasize the importance as well as what to look out for. They recommend using risk assessment scores. I know you guys are all very well aware and you have your own iterations of this. And the ones that they propose for us is this risk assessment. I'm just going to go through this SVS VQI one. That's just one that our society promotes. It's based on our VQI data driven outcomes for these particular patients, for our vascular patients. And so you can kind of plug and chug a number of things and come out with it. And really all it is just to better inform the patients about certain risks. I'm going to be honest, I don't actually use this because I just like to use our institutional data and kind of what our outcomes have been here. When I talk to patients, most of the time they don't care, to be honest, about what all the numbers are. They just want to know what all the risks are, period. They don't necessarily know the numbers. There is one paper, if anyone's ever curious, a multi-center study on PMEGs that came out. It's an international effort that was made, Aortic Consortium, and included basically all PMEGs from all major aortic centers throughout really globally. And so the head honchos for all of these main hospitals and aortic centers came together, pooled their data to come up with general outcomes and recommendations. And the short of it is that it showed that it is obviously very feasible with high technical success, meaning high ability to position the stents where you intended to put them in a safe manner with good outcomes perioperatively. Major adverse events happened in up to a quarter, and reinterventions were high. So freedom from reintervention at about 5 years was about 50%. So half the patients by 5 years have gotten some sort of reintervention. Survival from aortic related mortality was 89% at 5 years. And so obviously this is going to be driven by whoever contributed the most data, and it's going to be a little bit variable, techniques vary, but it gives a general idea of how far we've come with these complex aortic repairs and how the survival is for these patients. So I think that was just kind of the summary, a little bit of an overview. I'm happy to take any questions. And then if we want, Vivian, I can go to that one question whenever you guys are ready. I think pretty easy one.
Yeah, you can share the question and the answer, and then we can go to like the questions from the audience.
Do you want me to just go ahead and talk
Yeah.
about the answer? Yeah. I think this is pretty basic one. What's not a major postoperative risk associated with FBEVAR? So SCI, you already know, endo leak, access complications, meaning where we enter the vessel, particularly the groins or the arms, or even the neck carotid exposures. Um, Pneumothorax is not a major complication. It's not something that we expect to see. And if we do, something went horribly, horribly wrong during the surgery, if that happened.
Thank you so much. Um, there is already a question in the chat. I don't Dr. Taylor was asking um that about like when you were making the graphs, like do you guys use I'm assuming he's saying like 3D printing to make the graphs or the stents.
No, so initially it wasn't 3D printing, although now there are reports some people do them. And some are even trying to commercialize it and do 3D printing that way. So we actually do have 3D printing colleagues here that just came, but we do it all on software on the CT scan. So that's why we want a very specific type of CT scan. We want a CTA, 1 millimeter cuts, to be able to have the accurate planning. We put it onto a software called 3Mensio, which allows us to map it out on a straight kind of linear platform. Some of it, there's a little bit of an art to it because you have to kind of think about the path of the wires and the bias of the stent graft based on the tortuosity. And so you have to kind of have a little bit of inkling of what that might look like, and then adjust and shift based on that. And so it's all originally just that software. And there are different iterations. 3Mensio, there's Terracon, et cetera, et cetera. Now people do use 3D printing. We have not done that yet because, right, quite frankly, it just seems more complicated to get a sterile 3D print version of it. It seems more costly as well, when we can just draw on a piece of paper. We don't even do that elaborate design planning anymore. It's gotten to the point where I think sometimes we'll just get a post-it, we'll just map it out real quick and then put it up there because there's not a lot of time for certain patients. So
How long, I mean, just for my curiosity, how long does it take you to make it? Because it sounds like you say that you just do it during when the patients are getting prepped and like anesthesia is going on.
yeah, so I would say the fastest we've probably done it in is 20-ish minutes. Depending on how many branches, depending on, obviously expertise. So when I first started doing it, it took me longer. It probably took me like an hour to do them. It also depends if you have a good assist to help you.
Got it. Before I ask more, are there any questions from the audience?
Hi, can I jump in? Can you hear me?
Yes, thank
Hi,
you.
this is Kang. Appreciate your talk, Dr. Pyun. That was really helpful. Um, I wanted to ask you, just thinking about post-op courses and some of the weird things we see sometimes. We'll see a patient with either fever, or white counts, workup negative, thrombosis workup negative. Anecdotally, people say, oh, it's a TVAR fever. It's got a lot of graft. Maybe there's a physiologic response to that. I was just curious if you could provide some perspective on those anecdotal mentions.
Yeah, so there is a post-implantation syndrome, which has been well described, and it's kind of this surgery response after you implant a TVAR. Honestly, it should be a diagnosis of exclusion once everything else is ruled out. And even then, I tend to always keep infection in the back of my mind anyways. But the other things that it can be are, let's say it's a FBEVAR, if there was a renal infarct or something, and organ infarct, pretty most commonly it's like an upper pull or we lose a kidney or something like that. They have that serous inflammatory response. And so they can have a white count and or fevers and things like that. And so we want to think of probably the most worrisome thing, which is infection. And then if all else is out, then we think about post-implantation syndrome and or infarcts.
Thank you.
Fever though is pretty catchy. I think we should use that. I don't know who's saying that, but I like it.
And just to, while we're waiting for other people, if they have, in case they have questions. So I know post-op, you guys usually you guys get like post-op like scans within like 48 hours or so, and that usually helps you guys determine whether there's any issues right away, and then we can be less concerned for like stenosis.
We usually get the duplex first and see, and if they're clinically not showing any signs of it, so numbers are good, your output's good, et cetera, not necessarily. The one time I used to start off rescanning everybody, but then it's like, well, if you see a endo leak, but it's not maybe a super impressive one, what do you do about that? And so a lot of times some of those endo leaks will actually go away on their own. So unless I have a clinical suspicion, I won't necessarily rescan them post-op. The ones that I do are ruptures. If they're impending rupture or rupture, then absolutely I always get a post-op scan to make sure that it's contained.
Okay. I think we have a question from Dr. Fung.
Hi, thanks for the talk. I was surprised to see your how bad the outcomes are with renal failure, the low functioning and the ones on dialysis. Why do you guys think they do so poorly?
Are you talking about on that what is it?
I think it was a
This,
fever, EVAR. Yeah,
yeah,
yeah.
this one. Yeah, and so that one in particular, especially for open, but I think a lot of times renal artery stenosis and occlusion is the most common complication for the FB VARs, especially the TAMBs, et cetera. And then also it's the contrast use. Also the patient population that we tend to treat have some sort of baseline CKD and or they're predisposed. And so that could be another thing, at least all from an endo standpoint. And then it's also not uncommon that we have to take, well, maybe not common, but we have to take accessory renals, things like that. And so we kind of keep pushing them on the edge. But the alternative is that they lose the kidney altogether.
Okay, thanks.
And this is for, I think, dialysis patients. I mean, their outcomes, no matter what, are poor. So this number you're talking about,
Yeah, but it sounds
yeah,
like this will just help. So I'm palliative care, so it would just help me when I'm kind of gauging how sick these patients are. But yeah, kind of like you're saying, a lot of the patients that you're already treating already have some kidney disease, if
yeah.
not significant. Yeah.
And it's interesting because sometimes people will joke. I used to joke like, where's the limit? Are we just going to keep throwing stents in everybody? Does that mean everybody gets a stent? And to be honest, at least when I talk to patients, I really want to make it known that it's not it obviously we have expertise here, but it's not benign. Like complications can really occur. And so what are their goals of living, goals of care for their life? Because some people will say, no matter what, I do not ever want to be on dialysis. And they have baseline CKD. I would rather die from my aneurysm before I'm on dialysis. And so I asked them very specifically, like, is that something that you've decided? Some people say, I never ever want to trach. And they're on HOMO 2 for 2 liters, 2 liter HOMO 2, and anatomically it looks like a beautiful endovascular candidate, but I can't guarantee them that I can extubate them and not have them get a trach, et cetera, et cetera. And so if they say that, then I'm like, okay, well, I need you to know that there is a respiratory failure complication potential. And so that has to be something you consider. Is that a risk you're willing to take? And so at least I try to individualize it based on patient specific factors. But as you've probably seen, we can throw it in anybody, like we can do a repair on anybody, but it's a very interesting question to have for these people.
I'll just add one thing, Alyssa, is that no, I think your group has been so awesome in calling us early. Lately, we've had just a lot of referrals when you guys are worried, you're still offering, but you kind of know it's going to be an uncertain ride and you're not sure how they're going to do afterwards. And we just been getting more and more engaged with the vascular population. So yeah, no, we think we have a great partnership with you guys.
Yeah, it's been very helpful, very, very helpful. Really appreciate you guys. Any questions?
Can you talk about, I think you guys have been doing a study recently about for patients who come in with type B aortic dissections in terms of like surgical management versus just like medical management.
Yeah, so type B aortic dissections, particularly in the acute and subacute phase, is something that we just don't really know enough about. And so, early studies, obviously, we were able to differentiate, okay, a type A versus a type B. There's very clear management styles that should be done for morbidity and mortality. But within type B, should you do a TVAR and at what time point is the big question, mainly because TVARs, especially when in the acute period, So when that dissection is fresh, that tear can propagate very easily. So there's a risk of retrograde. So that's where the tear propagates forward. There's a risk of it rupturing backwards, tearing backwards, et cetera, et cetera. There's a risk of spinal cord ischemia and stroke, as well as access complications, all of that. So is it worth all of those risks to put a stent in very, very early on when most of these people end up resolving their pain once their blood pressure is controlled? And so initially the treatment paradigm was just conservative management. You don't do anything. But what we found is that as you see, these patients come back and they turn into thoracoabdominal aortic aneurysms. So that weakened aortic wall then predisposes them to degenerating into full-blown aneurysm. Now we're treating a complex aneurysm down the line many years later. Well, is there a way we can preemptively kind of lower the risk of that happening? And so how can we promote remodeling? How can we stop that sooner before it gets to that point? And so then it's proposal, maybe TVAR is the way. So if you put a stent in early while the aorta diameters are still small, can you start to induce that remodeling earlier in order to decrease the risk of that happening, or at least decrease the extent? So you treat the top part, then only the bottom part's the part that you have to worry about. And so that's kind of the big question is, when do you put that stent and when do you not put that stent, at what timing? And so our Improve AD trial is basically uncomplicated. So people who are not ruptured or malperfusing, et cetera, they just have pain and a dissection. We randomize them either into medical treatment or into TVAR treatment arm. And then within the first 6 weeks, depending on the arm, so if they're in the TVAR treatment arm, then they have to get a TVAR within that first 6 weeks. And the idea is to cover the quote unquote entry tear, which is the origin of that tear. There's always a starting point that we're looking for. So it's covering that starting point so that the false lumen thromboses and promotes remodeling. So that's the current study. Obviously, anybody who comes in with malperfusion, rupture, high risk features, things like that, cold leg, stroke, et cetera, they get a TVAR no matter what. If anybody converts in the interim from medical management into malperfusion, they have a complication or persistent pain, they can still get a TVAR, and they just cross over into the other arm.
Got it. Thank you. And how closely do you guys follow your patients after surgery once they get discharged?
Yeah, so our typical post-op surveillance is 1 month post-op. The 3-month repeat scan and follow-up is dependent on how well they did at the 1 month and the level of suspicion that they're going to have a complication. Otherwise, it's 6 months. If that looks good, then it's annually thereafter. Once they get to a certain point, like, a decade out or something like that, if they get to that point, then it can be Q5 years, Q3 years, whatever it is. But a lot of times this patient population is getting endo for a reason, and so they're not necessarily out that far. Yeah, I think open is a different story because it's a physical construct. We're not scanning them every 1, 6 month, year, et cetera, et cetera. Honestly, a lot of that has to do with how the initial trials were done. So the initial trials for a lot of these stent grafts, for example, certain industries, certain companies, when they did their feasibility studies and all of that, that's how they were surveilling the patients. And so it ended up just kind of getting adopted. But it turns out there's such high reintervention rates that you probably want to surveil them that frequently anyways.
Thank you. That was a really wonderful talk. And any other questions from the audience? Since we're almost at the 1 p.m. mark. Okay. Just a reminder for everybody, the CME credit is in the chat. So if you can just text the phone number, you'll get the CME credit for this talk. And then you can just email Lena with like the answer to the question for your MOC credits. And if no other questions, then thank you again, Dr. Pyun, for giving us this talk. And have a wonderful day, everybody.
Thank you.